heart transplantation. I'm sure you find these useful. And continuing in the same vein, today we are going to deal with the topic cardio-oncology, which is of extreme importance given the close interaction between these two specialties when we deal with these patients. And we are very fortunate to have with us Dr. Susan Dent, who's a pioneer in this field, and an accomplished team of speakers led by Dr. K. Venugopal. So, without further ado, let me hand over to Dr. Hari Krishnan, President of the Heart Failure Association of India. Hari, over to you.
Good evening, ladies and gentlemen. After the two successful webinars which were well attended, we are now going to an important territory, cardio-oncology. We know it is emerging as a subspecialty of cardiology, and a lot of interaction between the oncologist and the cardiologist are required to manage these patients. When the first cardiotoxicity was described 50 years ago with anthracyclines, we now have the immune checkpoint inhibitors showing toxicity to the heart. So without much delay, we will go on to the topic. I invite Professor Venugopal and Dr. Rajesh to introduce the speakers and start the proceedings. Thank you.
Good evening to you all. As Professor Hari Krishnan has said, the relevance of cardio-oncology will be increasing day by day because you have an increasing aged population who already have cardiovascular disease, or you may be having another population who have received cancer drugs and having cardiac failure later on. So there has to be a very close interaction between the cardiologist and the oncologist. Even though this is a very nascent field, I believe that we will have a lot of interaction between these two groups of physicians for the better treatment of patients suffering from cardiovascular disease as well as malignancies. It's my proud privilege today to introduce the three speakers who are actually pioneers in the field of cardio-oncology. Dr. Susan Dent is the co-director of the cardio-oncology program at the Duke University, North Carolina. I have heard her in 2017 when she first came to Cochin, and I got introduced to her. And it was a time when I was thinking about looking at cardio-oncology as a special interest in the field of cardiology. Dr. Hisham Muhammad, I have also to introduce my Professor Purvesh Parekh, who is the Director of Asian Cancer Center and probably again a pioneer in the field of cardio-oncology. They have already started the Asian Cardio-Oncology Society, which is a very, very active society with more than 4 or 5 webinars in the last 1 month. I have been attending 2 of them, and I've been very impressed with the way they have been conducting the seminars. Dr. Hisham Muhammad is the Associate Professor of Cardiology at Amrita Institute of Medical Sciences. He has a very well-run cardio-oncology program. And my co-chair, again, Dr. Rajesh Gopal, is again a person who runs a cardio-oncology program at Apollo Hospital, Chennai. And it is actually Rakesh who really introduced me to this particular topic of cardio-oncology when he gave a talk on cardio-oncology. That is when we started thinking about this as a thing. Over to Rakesh for further continues the program. Rakesh, please.
I really the leading cause of death worldwide is cardiovascular disease, and it is closely followed by the deaths out of cancer. We all know these two. If you want to really prevent meaningful prevention of death across the globe, these two specialities needs attention. The problem with oncologists, problem with the cardiologist is that cardiologists are not very familiar with pharmacology of cancer drugs, and the oncologist is not very familiar with pharmacology, which is about the cardiac drugs. So cardiologist does not know about oncopharmacology and the vice versa. So these two specialties share common risk factors. If you look at the risk factors which cause cancer of the breast and CAD, is exactly same, and that is true with many of them. And cancer itself is a prothrombotic state, and cancer itself predisposes patients to develop fistula, hypertension. Cancer therapeutic drugs can cause hypertension and worsen hypertension. And these sort of things should, unless we work together, the cardiologists and the oncologists work together, we can never achieve meaningful outcomes. We all know about the drugs, the classical drugs like adriamycin, cyclophosphamide, causing cardiac side effects. But there are a lot of problems with the newer generation drugs. They actually much more frequently cause cardiac side effects, though the impact may not be as bad as adriamycin. And we have the challenge of a patient who was exposed initially to adriamycin and subsequently has to get something like herceptin, the trastuzumab. Then the risk of the problems increase. And we know the different types of the cardiac injuries. One is reversible, like that of trastuzumab, the type 2. So even if the patient develops liver dysfunction, these patients can be managed medically and then can continue the chemotherapy. And you know about drugs like in interactions between some certain cardiac drugs, the possibility of cardiac arrhythmias with prolongation of the QT, even otherwise drugs like erlotinib, dasatinib causing pulmonary hypertension, and the prothrombotic states associated with many of the cardiac drugs. And we should probably keep an eye open towards since some of the fast-tracked approval for many of the cardiac the cancer therapies, we really do not know what it can actually cause as side effects. Example, immunotherapy, when it was introduced first time, it was the thing about immunotherapy was that it does not cause cardiac side effects. That was the norm in 2016 to 2017. People are telling no, the what was happening with the older generation of the drugs are completely gone. There are no more cardiac events. But we know the incidence of the reported incidence of immune-mediated myocarditis in immunotherapy is really low. Even if you use two agents, about 2.4%, one agent 1.6%. But reality is that the mortality is very high, up to 49-50% for a patient who has fulminant myocarditis. So you can't have a side effect like that
Rakesh?
because the PDL1 is protective for avoiding an immune-mediated response on the heart. We all know suppressing that could lead to an immune response. So we need to interact. We need cardiologists and oncologists needs collaboration, and we keep saying like no, fight heart and fight cancer with all your heart.
Okay, I think now we'll go to the first talk. Let me invite Dr. Purish Parikh to give a perspective from the oncologist. As far as India is concerned, we need to build up cardio-oncology services, a much more robust cardio-oncology services in India. So therefore, we want to know the perspective from the oncologist, what they expect from the cardiologist. And then later, Dr. Hisham will talk about the perspective from the cardiologist side. And Dr. Dent will give us an overview. This is the program that we have envisaged. May I invite Dr. Purish Parikh for his first talk, the perspective from an oncologist's viewpoint.
Thank you very much. I hope my slides are visible.
Yes.
Okay. So I thank all the organizers, Vijay, Harikishan, Venugopal, Hisham, and Rakesh for giving me this opportunity to talk with you. I'm going to keep my session very simple, and I'm wearing two hats right now. One is as an oncologist and one as a medical legal expert. And I think both are really important for cardio-oncology specialty. You will see my transition from black hair to white hair. And during my lifetime, my professional lifetime, the chance of cure in a patient with acute lymphatic leukemia has gone up from 10% to as high as 96%. So patients with cancer are doing better and they are getting cured and they will live a full life. So what is this full life? If you look at National Geographic, this baby born in Western Germany is going to live up to the age of 120 years. And if you look at Time magazine, they are predicting 142 years. So as Rakesh mentioned, lifestyle diseases like cancer and heart are going to be together, and we are always going to be required to help this sort of. Now look at what was happening at the airport before the COVID pandemic. Okay, the bottom photograph represents people queuing up at the manual counter, which are hardly any. And the top part represents people queuing up at the kiosk for a self check-in to take the boarding card. So basically, all of us are enamored by technology, and we use the technology thinking that we are in control of everything. And the other intriguing part is outside of the hospitals, the largest number of wheelchairs are at airports. So what does this mean? It means that we are getting older, We are having limited mobility, but we still want to see the world. And therefore, we are having expectations of traveling across the globe. So, this is the problem that we face today of patients having unrealistic expectations. You see this dismembered mannequin, and then when the patient comes, they will still want us to resuscitate the patient. It's like asking for a male sales guy, asking for the impossible. And if you look at Asia, this is might be the situation as published in the newspaper. It says that in India, doctors spend less than 3 minutes in a consultation. And it is reasonable to understand that patients are dissatisfied if this is actually a reality. Fortunately, if a patient already has a pre-existing cardiac mobility and then develops cancer, as an oncologist, it is very easy for me because the cardiologist is already involved. It is his patient, and therefore there is a co-ownership of what we move for. Unfortunately, that may not happen when a cancer patient develops a cardiac issue for the first time. And we are always worried whether the cardiologist will say something that might actually be misinterpreted by the patient. So let me share a positive story, and this was discussed in our seminar earlier. A patient had come with colorectal cancer, and he was given 5 infusions. The baseline left ventricular ejection fraction was 60%. After the 5 infusion, immediately it fell down to 15%, and I was worried that we are going to lose the patient. But when the cardiologist walked into the picture, he said that this patient will go home walking. Please do not give up. And a balloon was put in, and 2 days later, his ejection fraction was almost normal. On the third day, we went home walking. So I think this is the success story that we must join hands together to ensure that this happens in each and every patient. In oncology, there are many ways of treating the same patient. And here I've taken the example of a locally advanced breast cancer patient who would require an anthracycline as well as trastuzumab. As per level 1 evidence, if the patient is hormone receptor negative, HER2 positive, there are three ways of dealing with the patient. Either we give neoadjuvant chemotherapy followed by surgery, or we give chemoradiotherapy, and then the patient might also get maintenance with trastuzumab that might go on for 1 year. And each of them is correct. So we always have a multidisciplinary tumor board that tells us what to do. Originally, we were meeting face to face in a conference room, but now we continue on a virtual platform. And you can see that it includes surgical oncologists, radiation oncologists, medical oncologists, the pathologists, as well as hospital administrators. So this is a collective decision, and we hope that between cardiologists and oncologists also we can emulate and do this equally well. There are other factors that come into consideration when we are treating patients. And this is one example of the financial or socio-economic situation. So in India, we have 15% of the patients who are rich enough to afford anything out of their own pocket, or that they have the best insurance like CGHS, and therefore they can be given the best and treatment in the world. On the bottom right hand side, you see 50% of the patients who are too poor to do anything other than follow the government schemes like Ayushman Bharat, and they are limited by what the government approves or does not approve. Just as Susan was saying, that people without insurance can get a test done for COVID, but they may not be able to get the treatment. But really, where we need to join hands is for the middle class, and this is 35% of our population. 35% of 1.2 billion is 360 million, which is more than the entire population of United States. And besides the socio-economic background, there could be comorbidities, there could be other local problems that they might face in terms of mobility, in terms of looking after children, having a nucleus family, so on and so forth. So in this digital era, are we doctors ready for this? There is so much information overload that I cannot even read what is published in the English language, let alone remember it. Also, patients have an instant, real time, and remote access to everything that is on the internet. And this includes myths and beliefs which are overshadowing facts. So many times patients come saying that I want so and so treatment, which is actually not effective in that. So in order to give personalized medicine, we must also personalize our communication strategy. And this is a personalized communication strategy based on patient's personality, the chapter that we published in this book in Springer. Professor Susan Dent will be talking soon, and she has been a co-chair for the program that we have done. We have finished 6 programs, and then tomorrow is going to be the 7th one, where Dr. Devi Shetty and Dr. Arjun Ghosh from United Kingdom will be speaking. So my request to our cardiology colleagues is as follows. We respect your valuable professional opinion and need your help. Please listen to us with an open mind. Please don't presume causality just because a patient has been given a specific chemotherapy drug. Together, we need to focus on the solution, not on the problem. And both of us should present the same clinical identical picture to the patient party so that there is no confusion, no loose talks, and no medical jousting. As far as the medical legal risk is concerned, in India, we can divide them into 3 categories. Patients with perception of negligence while the treatment is ongoing, and this can be easily sorted out by effective communication. But the other 2 categories are increasingly causing a problem for us, and where communication cannot do anything. One is when the patient wants to avoid paying hospital or doctor fees, and the other is when relatives are instigated, often by some of our own colleagues. So whenever I see a patient, this is in a lighter vein, I tend to divide them into 4 categories. On the vertical axis is the mental risk that I can face. On the horizontal axis is the legal risk that I face. And we are talking about the hen, the lion, the pig, and the mosquito. So what do they represent? The hen is a nervous, concerned person. Am I going to be all right? What is going to happen to me? What am I going to do today? The pig is the careless, indifferent person who will not follow instructions, will fail to take treatment, and say, oh, nothing is going to happen. The lion is the bully or the VVIP who always pulls up his chest and says, you know who I am, you know who I'm connected to. And the mosquito is the nitpicking, complaining person who says, doctor, you had advised for this injection to be given at 9 o'clock. It is 3 minutes past 9, but the nurse has not given this injection. So this is the sort of people that we have to face. And please remember, all of these are potentially dangerous to healthcare professionals. So we have the 50 crore question in front of us. What is the future of cardio-oncology? And it is to have the patient as the focus. So let us assume that the zebra is the patient and the lioness is the cardiac problem that the cancer patient might have. If we join hands together, we can provide the zebra with a motorcycle, and therefore the problem will be far behind. And with this, I come to the end of my presentation, and I always end by saluting our armed forces because we are enjoying our independence because of what they are sacrificing at the border. With that, I stop here, and thank you very much for a patient hearing.
Thank you, Dr. Parikh, for that excellent presentation. I think without wasting time, we'll go to Dr. Hisham to present the perspective from a cardiologist. Dr. Hisham, please.
Yeah, can you see my slides, sir?
Yes.
Yeah. So some problem in moving my slides. Yeah. So good evening, everyone. So I think in the next 10 minutes or so, I'll just quickly give some perspectives from the cardiologist side, especially within the context of the discipline of cardio-oncology. So the interface of cardio-oncology, as some of the speakers have alluded to, is quite an interesting one. And it's probably the need of the hour when you consider the needs, the cardiovascular needs of the oncology patient. And as you know, many of the anti-cancer agents have brought significant survival benefit to the patients with cancer. But at the same time, that survival benefit has been attenuated to a large extent in certain populations by the cardiovascular risks of cancer therapy or by the intrinsic cardiovascular risk factors which the patient may possess. So cardio-oncology, essentially, it exists at a zone at the cross-section of three determinants. It's at the intersection of cardiovascular risk factors, cancer therapy, past or present, and cancer biology. And the overarching, or the overarching goal of this discipline is to optimize oncologic benefit. At the same time, maintaining it within the confines of acceptable and minimized cardiac risk. In other words, we want the patients to survive their cancer with great survival outcomes, but at the same time, we want them to do so with reasonably stable or acceptable cardiovascular health. And you can view these paradigms through two windows. And one of the windows is to address the cross-section, the area of cross-section which lies at the interface of cardiovascular risk factors, cancer therapy, and cancer biology over here, where we're looking at largely treatment-related cardiotoxicity. And on the other hand, if you look at it another way, you can also look at the intersection over here, which actually represents incident cardiovascular disease, which has no relation to cancer therapy, but at the same time, it may limit the patient's ability to receive the best cancer therapy possible. So cardio-oncology as a discipline broadly looks at these two paradigms and tries to come up with the best treatment options, surveillance options, and evaluation protocols for this high-risk group of patients. So I just thought I'll sum up certain key cardiovascular perspectives in terms of the in the context of cardio-oncology. So as Dr. Rakesh mentioned earlier, I think the first and foremost is the drugs and mechanisms. Of course, we started with the prototype cardiotoxicity model in 1960s with anthracycline-based chemotherapy, and it's something which we fairly understand right now, although there are certain instances or certain aspects which still need clarity. But at the same time, oncology drugs have undergone a tremendous explosion of the last decade with the arrival of immune checkpoint inhibitors and its attendant risks of myocarditis. We have tyrosine kinase inhibitors with its attendant risks of hypertension, pulmonary hypertension, systemic hypertension, and thromboembolic events. So I think it's very important, speaking from a cardiologist's perspective, that we must keep up pace with the pharmacology of novel anti-cancer therapy so that we clearly understand the risks which are posed to each patient. Second, what are the predictors of cardiotoxicity? So essentially now we are essentially relying on the traditional cardiovascular risk factors or established cardiovascular disease in a patient to sort of predict where the patient falls along the continuum of risk for cardiotoxicity. So that often is incomplete, and it's essential to understand that we probably need more accurate models and we need more longitudinal data to sort of tell us where to go in terms of accurate prediction of this of cardiotoxicity in a given patient. And of course, cancer therapy-related cardiac dysfunction, when do we diagnose it, and what do the criteria mean? And that's essentially an imaging criteria, which we'll come to when we discuss about the echo, but that's something which we also need to understand. When do we diagnose a patient with CTR-CD, and what does that tell us in terms of the patient's outcome and management? Considering cardioprotection, there's been a lot of talk about the use of ACE inhibitors or ARBs, essentially RAS blockade, beta blockade in patients who are on anthracycline-based chemotherapy or sequential therapy with trastuzumab. And a couple of trials have looked at this with some positive data. So we are yet to have a very large clinical trial data set to sort of conclude more reasonable conclusions from that. But again, newer trials are on the way, and PRADA-2 is a trial which is now looking at the new drug class ARNI in cardioprotection in patients who receive these potentially cardiotoxic drugs. Prevention of venous thromboembolism is something which a cardiologist should always be aware of in cancer patients. And to this extent, the Corona risk score provides some guidelines as to predict the propensity of or the likelihood of venous thromboembolism. And of course, we have certain options in terms of DOACs or low molecular weight heparin to counter this risk. Cardiac biomarkers and imaging, if you consider them together, are our central tool for the cardiologist to define whether the patient has cancer therapy-related cardiac dysfunction or not. And we have various tools like troponin T and NT-proBNP, and the data is very promising, but we need larger data sets to clearly understand the implications of the rise of these enzymes during chemotherapy. And of course, on echo is the bedrock of our understanding of CTRCD. And of course, features like global longitudinal strain or 3D ejection fraction are well proven in understanding whether the patient has developed cancer therapy related cardiac dysfunction. And of course, cardiac MRI has proved its role in amyloidosis and myocarditis. It's also important to remember to adhere to guideline-directed medical therapy in patients with heart failure secondary to chemotherapy. Quite often, just because of their comorbidities, we don't often engage the full use of guideline-directed medical therapy in these patients when they develop heart failure. And I think it's very important to do that as a cardiologist. And of course, we must consider the use of newer drugs which are coming to the newer guidelines so that they will get the maximum mortality and morbidity benefit. And of course, survivorship care in collaboration with the oncologist is another step that the cardiologist should keep in mind. So this is a busy slide, but I'd like to keep it very simple. On the left-hand side, on the left panel, you see a flow of a sequence of evaluation where you have all these characteristics, demographic, cancer treatment characteristics, and you have the traditional cardiovascular risk characteristics and prior heart disease. And you utilize this in order to come to a conclusion whether the patient is at high risk or low risk in terms of their risk for cancer therapy-related cardiac dysfunction. And you input these findings and you can apply to the workflow on the right-hand side of your screen, and you can divide them into low risk or high risk. The low risk patient will go into serial monitoring, and the high risk patient is the one which needs to be referred to a cardio-oncology service. And as this patient goes down, the cascade of evaluation needs to be looked for the development of the whole gamut of cardiovascular involvement according to the therapy the patient has received. So essentially, with this background, this is essentially the structure of a cardio-oncology service, where you have to define a practice pattern in your institution where you need joint meetings with the oncology colleagues. You need to sort of plan together and decide what will be the criterion for referral from the oncology side to the cardio-oncology service, the cardiologist in particular, and of course to decide on what are the standard tests which are available in the institution for risk stratification and evaluation, and to understand how these tests fit in with the decided protocol. And of course, we need to implement this coordinated service between the two divisions of cardiology and oncology, coupled with patient education, health staff education, standardization of care where you have mutually decided protocols for the treatment of such a patient. And of course, it all counts for nothing if we don't identify the patterns from these data sets. And research is a big part of identifying these data sets in a given population within an institutional protocol. So to summarize, cardio-oncology team is essentially a multidisciplinary approach where clearly the cardio-oncologist is a cog in the wheel, and the whole team is a collection of members belonging to multiple specialties, all with the singular aim of optimizing the cardio-oncology outcomes for a given patient. Thank you for your patient listening.
Thank you. Now we look forward to the keynote talk by Professor Susan Dent, who is a pioneer in the field of cardio-oncology. And I would invite her to give a talk, and then we'll have the discussion after the keynote address. May I invite Professor Dent to give a talk? Dr. Dent, please.
Thank you. Hold on, maybe I'll just minimize you. So thank you for inviting me. Can everyone hear me fine?
Yes.
Yes.
Great. So thank you for inviting me to give this talk. And some of what I will discuss has been previously mentioned by the two prior speakers, but I'm going to give you my overview of cardio-oncology and how collaboration between cardiologists and oncologists can ultimately improve care for cancer patients. So just to give a scope of the problem, and many of you are all may be aware of this already, but about a third of patients receiving cancer therapy today will have some form of cardiovascular.
Slides have not come.
Oh.
The slides have not come.
Oh. Okay, I had shared them previously. What happened?
Ma'am, share it again, ma'am. Can you
Share
share it?
again? Hold on. Can you see them now? No?
No.
Hold on. I have to share them again, maybe. Let me get out of this. End show. And how do I share them again?
And you have to just click on share screen.
Yeah, I'm trying to bring up the share screen again. I don't know where
In the
it's
Zoom
gone.
and share, click on the share screen, ma'am.
Oh, share. Oh, wait a minute. There. Share. Move this to cloud to share. Uh-oh. Okay, hold on. Okay, now it's not doing anything. Hold on. Open. Hold on just a sec. Oh dear.
Just disconnect audio from one device.
Yeah, I'm just trying to share it again. Hold on. Why is it doing that?
Disconnect audio from one device.
I'm going to sign on again. This is not working. Hold on.
Susan, your two devices are connected. So
Okay,
that's
hold
what
on.
yes. That's right. Fine.
Okay, is that better now?
Yeah.
Sorry, guys. Okay,
It's okay.
let's start again. Technology. Okay, so thank you for inviting me to speak at this meeting. And over the next 20 minutes or so, I'm going to give you my sort of viewpoint on the collaboration between cardiologists and oncologists and how can that lead to improvement in care for our cancer patients. So we know, as alluded to previously, that the population is aging around the world. As you see here, it's estimated by 2050, there'll be about 23 million people in the US, at least over the age of 65. And we know that cardiovascular disease in general increases with increased age, both in men and women. And so does cancer increase in terms of age. And so as are alluded to previously, as our population ages, we can expect to see more cardiovascular disease and more cancer as well. The good news is, from an oncology perspective, is that if you look at this diagram published a few years ago in JACC, there are a huge number of cancer drugs that are in development to treat malignancies. And so that is encouraging. And of course, what we also know is based on earlier detection and treatment of malignancies, the projection of cancer survivors is increasing around the world. These are US numbers, but you can see year after year, the number of cancer survivors increasing. So not only do we have to worry about the treatment of patients acutely, but what happens to them as they move into the survivorship part of their care. So what is the cost? So yes, we are making improvements. People are living longer with either active cancer or they're surviving their cancer, but what about the other side of that? And what is the cost of their treatment? Well, this just represents some of the different classes of cancer drugs and the respective cardiovascular costs that we have seen associated with them. So we've not long known that anthracyclines from the 70s are associated with heart failure based on total dose. And then, as was previously mentioned, HER2 targeted therapies came in the early 1990s that led to increased risk of heart failure, particularly when given concurrently with anthracyclines. We then saw the introduction of anti-VEGF therapy and tyrosine kinase inhibitors such as sunitinib, which was associated with hypertension, proteasome inhibitors, and some of the hematological malignancies came on board, such as carfilzomib, and it's associated with hypertension and heart failure, and checkpoint inhibitors, which are used in just about every malignancy now, and most recently in breast, associated rarely with myocarditis, but if people do get myocarditis, it's quite fatal. And then what I haven't put up here, of course, is of the newer therapies such as CAR T-cell therapy, which is sort of taken off in the hematological world as well. So these therapies have made great inroads in terms of treatment of cancers, but all have their own unique cardiovascular toxicities. We also know there's downstream effects of cancer therapy. So this was a paper published a few years ago by Lee Jones looking at breast cancer patients 3 years out from treatment. And he measured their exercise capacity in terms of their VO2 max. And what you see in red here is that a 50-year-old woman 3 years out from her breast cancer treatment had a VO2 max that was equivalent to a 70-year-old sedentary woman. So clearly, not only are there effects acutely with these therapies, but there are long-lasting effects that affect patients in terms of their morbidity. We also know there's an impact on radiation therapy. So on the left-hand side of the screen here, you see some data from pediatric cancer survivors showing you the cumulative incidence of cardiac events for those patients who received radiation. This would have been involving the heart field. With or without anthracyclines. And as you can see by the blue line, clearly the exponential increase in risk of a cardiac event, particularly by the time these pediatric cancer survivors get into their 40s. And then there was this pivotal paper by Sarah Darby, published in the New England Journal, looking at the mean dose of radiation to the heart in breast cancer patients, showing a proportional relationship between every increase in gray of radiation and the increased risk of a coronary event. So clearly it's not just, chemotherapy and targeted therapies, but it's that combination of those therapies and radiation therapy as well. And now we also see there's emerging evidence to suggest that there are competing causes of death. So as a breast cancer oncologist, I always worry about breast cancer recurrence and mortality from breast cancer. But as you can see in this study that was in postmenopausal women treated for breast cancer, that at about 8.5 years out from their diagnosis, they were more likely to die of cardiovascular disease than from breast cancer. And we know that, as I mentioned previously, that there is an increasing number of drugs that are coming into the clinic for the treatment of cancer. And so this diagram that I've modified from Javed Malehi from Vanderbilt, just speaking to the number of different drug classes that are out there. For instance, we have CDK4/6 inhibitors now in breast cancer that can lead to QT prolongation. There's now PI3 kinase inhibitors in metastatic breast cancer that can lead to hyperglycemia and metabolic syndrome. So we are, I think, just at the tip of the iceberg with the number of new therapies, mainly targeted therapies, that are now coming into the clinic for our patients. So what are the challenges in the treatment of cancer in 2020? Well, I've shown you that the population is aging, so it's at risk of cancer and cardiovascular disease. And of course, with the aging population, we have those patients with pre-existing cardiovascular disease at the time of their cancer diagnosis. We then expose these individuals to cardiotoxic cancer therapies, such as the drugs that I've already mentioned. And then they may have radiation on top of those therapies. And of course, patients are living long enough to develop secondary malignancies and sometimes even third malignancies, or they develop recurrent malignancy. So when we're treating them in that context, we have to take into account what they've had previously. So any one of these things can perhaps stop or may stop the oncologist from providing that patient with the optimal cancer care. So who is responsible for patient care? Well, and this is cartoon I borrowed from Danielle Cardinelli from Milan, showing you that, traditionally, if you were the oncologist and the patient developed an issue, it was the cardiologist that was responsible because they developed cardiac disease. And if you were a cardiologist, it'd say, well, they've got cancer, it's the oncologist who really should be taking care of the patient. And there really was no communication between these two entities. We really did operate in silos. So I think the birth of cardio-oncology really came from the idea that as oncologists, we want to provide the best cancer care, but at the same time, we want to work with our colleagues to optimize cardiac health. And that may be, dealing with people who have risk factors at the beginning of the cancer therapy, or they may have already overt cardiovascular disease. And so by definition, I think what we can call cardio-oncology is a clinical-based discipline focused on the cardiovascular health of cancer patients and cancer survivors. Well, if that's cardio-oncology, what is a cardio-oncologist? I get asked this question all the time. And I think, we can define this really as any healthcare provider who's focused on the prevention, early detection, management, and recovery of cardiovascular function potentially resulting from cancer therapies. So it certainly can be a cardiologist with expertise and interest in this area, and it can be an oncologist also with interest in this area. Cardio-oncology is relatively new for most of us, but it's not for some of us. So this is a paper that was published in a Italian journal by Danielle Cardinelli over 23 years ago now. Just as a note that they were pioneers in this and recognized that almost a quarter of a century ago, the importance of consideration of treating patients in this collaborative fashion. And over the last decade or so, there have been cardio-oncology clinics emerging globally. I have to update my hearts on this diagram, but you can see clearly the interest in establishing clinics and programs has grown exponentially, particularly in the last 4 or 5 years. And we've seen the development of cardio-oncology partnerships through a number of different organizations, both on the cardiology side and on the oncology side. And we've even seen organizations develop special cardio-oncology sections, such as the American College of Cardiology, the European Society of Cardiology, and also now the American Heart Association has a cardio-oncology council as well. And so we've really seen the support of development of cardio-oncology partnerships. And we've seen a number of manuscripts and papers come out over the last few years, which provide some guidance and best evidence on how to manage our patients. However, I will say a caveat to all of these is that many of these papers are based on expert opinion, because at this time, there is very limited level 1 evidence for some of the recommendations in these papers. And the most recent paper that came out was by the European Society of Medical Oncology just in this January of 2020 in the Annals of Oncology. We've also seen that a number of countries have established cardio-oncology programs. And as you'll see, India is in this circle. And I think this is great. I say that international collaboration is essential if we are to move forward the field of cardio-oncology and to gain better evidence to help guide us in the treatment of these patients. This is under construction because hopefully moving forward, we'll see more and more countries joining and developing cardio-oncology programs within their respective countries. And we've also seen that many of these countries now are becoming part of the International Cardio-Oncology Society, which has a mandate really of promoting patient care, education, and research. And so I know that different societies are joining ICOS, and this is something that I've also been involved with and am currently working with to help countries and promote this for them, to support countries who are interested. But back to the question, does collaboration between oncologists and oncologists really improve patient care? Well, I guess that depends on how do you define improved patient care. So from an oncologist perspective, that may mean completion of prescribed cancer therapy, improved cancer outcomes certainly would be a way to define it. Is it improved cardiovascular outcomes? Is it prevention of long-term cardiovascular sequelae of cancer therapies? Or is it patient satisfaction? And I would argue that for any of these, there's limited supporting data. And this is really an area of unmet need. It's certainly an area that we need to focus on. But let me just give you some examples of papers or studies where they've tried to address this question. So back in 2008, when I started our cardio-oncology clinic back in Ottawa, Canada, what we did is we started collecting data. We developed a registry, and all of the patients that were referred to our cardio-oncology program. And I thought it was important at that time to start publishing some of our clinical experience of what our patients, what we were seeing in terms of referral patterns and how our patients were doing. And this is just sort of one example of data that was presented at the GCOS meeting a few years ago, showing you that at that time, patients with breast cancer who were being treated with HER2 targeted therapies that had mild or even moderate to severe cardiac LV dysfunction, the majority of these patients, through interaction referral to our cardio-oncology program, were able to complete their prescribed cancer therapy. So that was sort of one way we were looking at trying to determine the impact of having a cardio-oncology clinic. This is some data actually published just this year, looking at a retrospective review of cardiac adverse events in patients with CML with prescribed ponatinib. So they looked at before 2014 and after 2014. This is data from actually the Moffitt Cancer Center in Florida. And you'll see that before 2014, very few patients were referred to cardio-oncology, 2.7% of the sample. After 2014, 51%. And what they found is that there were statistically significant fewer cardiac adverse events in the patients being referred to cardio-oncology. And there were a fewer number of overall cardiac adverse events. So small study, single center, but clearly showing you, or at least providing some evidence that there may be some benefit to having these patients seen in a cardio-oncology clinic. This is data from Alex Lyon and his group at the Royal Brompton Hospital. Again, one way you can look at this is improved patient outcomes is through patient satisfaction and feedback. And certainly this is what they surveyed. 185 of their patients referred to their service. And the majority of these patients felt that this was, felt that this was a very positive experience. So that's another way, you know, we can measure the impact of having a cardio-oncology service. And then I think, you know, the other way that we can look at this is by collecting data. So while we have limited, currently have limited data on outcomes of patients referred to these cardio-oncology services, I think it's important to start considering how we collect the data. So this is a registry led by Dr. Dan Lenahan from WashU called the SURVIVE Registry. It's Cardiovascular Toxicity and Cancer Improvement and Recovery Registry. So they are actually collecting data on cancer patients who've received or are receiving chemotherapy, targeted agents, or immunotherapy, plus or minus radiation. They're collecting serum, plasma, saliva at baseline 6 months, 12 months, and then yearly for 3 years, as well as cardiac imaging. And so hopefully by collecting this type of data, we will be able to determine what type of patients that might be referred, and hopefully some outcome data as well. So this database will also have some outcome data where investigators can go in and access it afterwards. And then you may have heard of the Cardio-Tox Registry in Europe, and they published their findings in 2020. Again, not so much looking at the benefit of, you know, referring patients to a cardio-oncology service, but trying to identify who might be referred to a cardio-oncology service and what was happening to these patients. So in this paper, they looked at close to 900 patients over 24 months that were receiving anti-cancer treatment, and they divided them into 4 categories, looking at basically normal patients with normal biomarkers, mild LV dysfunction, moderate and severe LV dysfunction. And they defined cardiotoxicity as new or worsening of LV function from baseline or during follow-up. And that what they found is that about 3% developed moderate cardiotoxicity according to this definition, and about 3% severe. But more importantly, they looked at mortality rates as well. And the mortality rate was 22.9 deaths per 100 patient years in the severe group versus 2.3 deaths per 100 patient years in the remaining groups. So this information, I think, is also valuable when it comes to determining who should be referred proactively to a cardio-oncology service. And so this is my own idea of what cancer care should look like in 2020. I think that as oncologists, we have been very focused on planning their cancer therapy for our patients, whether that be chemo or targeted therapy, radiation therapy, and so on. But we have to do a better job than that, working with our cardiology colleagues. I think at this point in time, it's really important that we start considering risk stratification up front to determine who should be referred to a cardio-oncology service and who might benefit from that approach. We then need to think about, what happens in not only the cancer treatment that they're receiving, but all the other risk factors such as smoking, obesity, cardiovascular disease, and their present risk factors for cardiovascular disease. Ultimately, for all of the patients that we treat with cancer, we want them to survive their disease, but we don't want them to survive their disease at the cost of having significant cardiovascular morbidity or mortality. And so at this end of the spectrum, I think we need to think about being more proactive in adopting things such as the ABCDE approach that has been published by Jahavid Wallahi, looking at, again, addressing cardiovascular risk factors and disease up front and dealing with them. Also a nice paper looking at the role of cardio-oncology rehab and exercise in the management of cancer patients throughout their treatment and following completion of their treatment. All of these things need to be considered. And I can say as oncologists, what we haven't done a good job on is actually considering risk stratification up front. So we tend to act in a very reactive manner whereby we wait until our patients develop cardiovascular issues that may preclude them from having further cancer treatment. Then we refer them to cardiology. But really, we have to now be more proactive in the upfront risk stratification area, whereby if we have patients who are at high risk, these are the patients that need to be referred to cardio-oncology so that we can at least maintain their cardiovascular health and hopefully not worsen it with their oncological treatment. So just some of my key messages. I think that cardio-oncology clinics programs have emerged globally to optimize the delivery of cancer therapy without compromising cardiovascular health. But we really need to develop measurable outcomes, such as reduction in cardiovascular admissions, such as completion of cancer therapy, to help foster and sustain cardio-oncology programs. I think that many programs are starting around the world, but we have to have measurements of these programs. We need to actually objective measures to define the success of these programs, and that's important for patient care as well. And I would encourage international collaboration amongst healthcare providers to advance clinical care, education, and research to promote the growth of cardio-oncology and to promote the evidence that we need to carry this field forward. And with that, I will conclude, and I'm happy to answer any questions that you may have.
Rakesh? Thank you, Professor Den, for an excellent overview of the cardio-oncology, what is expected from the cardiologist as well as the oncologist. There are a lot of areas where there has to be a close interaction between the cardiologist and the oncologist. There must be a lot of questions from the audience. Rakesh, do you have any comments before we leave it to the audience?
The problem what we really face is that when a cardiac side effect occurs, then the oncologists sometimes get offended, saying like, no, it's kind of a fact, your fault finding. There is no cardiology services are complementary, and we need to work together and then get off the best possible cancer therapy the patient should receive. The uninterrupted cancer therapy is something which a cardiology service can actually offer. I mean, it's not about, more than, see, we need to make the doctor, the treating doctor, more aware of this cardiac side effects. And see, a patient comes to you with cancer and then you treat them, and now patient develops cardiac side effects. Now, then most of the time, the reality is that patient being told you have cancer, now there's a cardiac event, there's a cardiac problem, so stop treatment for both. That's exactly what happens in many instances. And this is where we need to intervene. We need to talk to both the cardiology colleagues and the oncologists and make sure such patients are treated. And many times I've seen, I've heard personally, like, no, this is a cardiac failure. Now this is a kind of a relief, eternal relief from the cancer, the cardiac death.
Yeah.
If someone has actually cancer and if somebody survives cancer for 5 years, the chances that this patient is going to die out of cancer is really low. Most of the frequently, the cause of death is cardiovascular disease. So all the risk factors, including diet, exercise, counts. So the survival is about that person, whether he survives cancer, whether he survives cardiovascular disease. And then reality is we need to do both. We have
I think.
Yeah.
Yeah, I think that what I didn't have time to talk about is we always have to look at competing risks. And certainly, you may have a patient like I have right now, a young woman with a HER2 positive breast cancer, actually a stage 3, at very high risk of dying of her breast cancer if it's not treated. On the other hand, she had an H1N1 induced cardiomyopathy diagnosed several years ago, and her ejection fraction hovers between 35 to 40%. And so, do I not treat her cancer and just say she's got a very compromised heart and let her die of breast cancer? Or do we try, and do whatever we can to optimize as much as we can her heart function so I can treat her cancer? And I think that decision can only be one that is had between both oncology and cardiology. Certainly, I can't answer the question from a cardiology perspective, but I do know, all I can say, if I don't treat her, there's a very high likelihood she will die of her breast cancer.
In my experience, the majority of the patients, more than 99% of the patients who develop cardiac side effects, especially LV dysfunction, is eminently treatable, and we have put most of them back to cancer therapy. Having said that, it's not the cardiologist to decide what kind of therapy for cancer should be given and what kinds of chemotherapy is to be given. We are here to tell how you can give the best possible therapy. Like you say, somebody gave adriamycin and then the patient has LV dysfunction, ejection fraction comes 45%. It's not up to you to say stop it. It's rather like, no, you treat the pump failure. Even though the myocyte necrosis, which is associated with doxorubicin, is permanent, there's myocyte necrosis, but the pump failure is eminently treatable. Now, we have clear evidence to say that even if you don't do dexazoxane, the standard heart failure therapy works. And these patients could really be put back on the chemotherapy which best suits them. That is important. The patient will get possible cure for cancer.
I do agree that cardiologists are more at fault. Basically, because the moment you see an LV dysfunction, we tend to say that no further chemotherapy, I think you stop it. This is something which most of us have faced. I think that is where the cardio-oncology interface really comes in. We have to discuss, this is the exact area for the development of the cardio-oncology interface between the cardiologist and the oncologist. Because we tend to be scared because that is something that which we have to change in our own mind. Then only I think we can provide the patient an adequate medical care. That's exactly the point of all this talks are probably this particular issue.
I think Dr. The Hari will remember when I spoke about heart failure meeting about cardiac oncology, one of the senior professors of cardiology stood up and said, you said continue chemotherapy. Common sense and real teaching is that if you gave one drug and if that causes side effect, you are supposed to stop it. And he didn't stop there. After the meeting also, he came up and really fired me. I couldn't convince them that no, this is I can't tell that's an old thing, but reality is that cancer needs cure.
Yeah, this is like what
Yeah.
happens with the cardiologist and the cardiac surgeons. We have a heart team where we make a decision together. So the cardio-oncology should be like that heart team where
Yes.
where we sit together and make a decision. I think such a forum should come up. Then
Yes,
only we can go together. I think all such facilities should have a. The heart team is functioning very well. So
no,
everywhere we take combined decisions and it is acceptable to both the parties. So
I
and the
have,
patient.
I
So
have
like that,
a
if we can form such a heart team, it can be the heart team or a cardio-onco team. Such forums can improve the outcomes of these patients.
I
When I
think
started
the
the cardiac-oncology program in
the more important
2006,
point. Okay, Rakesh, continue.
when I started the cardio-oncology program in 2006, it took about 3 years for me to convince that I am complementary, but I am not finding fault. So it took some time to convince the oncologists that we can work together and that can make a big difference.
No, the
So,
question is,
Susan was saying something.
one question is, suppose these are all possible in larger centers with large number of cardiologists and oncologists. The question is, how do you develop programs in smaller centers with probably one or two cardiologists and about 5 or 6 oncologists, where there is, so that is a challenge for us. In major centers, to build up a cardio-oncology team is not a difficult thing, but in smaller centers, where there are limited number of
right.
doctors, even there also, I think it is still possible to develop this interaction between these people.
I agree. And certainly it's no different in the US where you have a lot of community cancer centers where there may be, limited cardiology resources. But one thing that I'm involved in, and I start to set this up in Canada, is I think we can start leveraging telehealth and
Yes.
teleconsults, because for some of these smaller centers, they may not have the infrastructure to run a whole program, but they may be able to, submit a question via telehealth, or you can see a patient. So COVID-19 has really pushed that to the forefront in the US. And now we're seeing more and more patients. We're doing consults, via that mechanism. So I would say, because of the amount of work and infrastructure support to run a program, that in smaller centers, we should look at extending out our reach and offering, think about offering telehealth services for those centers, because many of them just won't have the infrastructure to set up a whole program. But you can also invite those people who are interested in those centers to join any of your CME events and have them come on board that way as well.
Yes.
I have a question to Hisham.
Yes.
Hisham, so you are running a cardio-oncology program for the last 3 years. So what is the basic
Yes, sir.
things which you, what are the basic infrastructure you have create or developed, or the programs you have developed as part of this initiative? Basically, you have an echo machine dedicated like that for
Yes.
the viewers. Yeah.
Mm-hmm. Yeah. Yes. So I think, as previously described, so we have identified within our cardiology group 3 consultants, and we've identified a parallel group of 3 or 4 consultants in oncology. So essentially, we form the sort of a core group, and we have, in terms of availability, we have not chosen to locate this at a third space in terms of location of the clinic. So basically, we have decided that these patients will be referred to the cardiovascular cardiology OPD, basically, for consults from the oncology group. That's one in terms of logistics. The second thing is, so within the existing echo room infrastructure, we have identified 2 echo rooms in which all oncology patients will have their echoes done in those machines, in which we can do a global longitudinal strain. We can do a 2D speckle echo tracking. So we have made sure that at the entry point, when the patient comes for an echo appointment and the patient comes from oncology, so essentially by default, the patient will go into an echo room which is capable of a machine which is capable of recording a 2D spectral tracking echo strain. So essentially, after this, if the patient has a consult, the patient comes back to cardiology OPD and will visit one of the pre-designated three cardiology consultants who's a part of this cardio-oncology group. And then we'll provide feedback to our cardio-oncology oncology colleagues with the same. The other additional thing what we have done is the oncology team has given us a space now in the tumor board meeting, where at the regular tumor board meetings, now it's a practice in our institute for one of the three cardiologists to be present when a patient needs to be discussed in terms of management questions of when the patient has a pre-existing cardiovascular issue, or the patient is facing a regimen which has a potential cardiotoxic problem.
I think we can add a cardiologist also in that picture shown by Dr. Purvish.
Yes.
I think
Yes.
we are missing.
There's one question from the audience. That was, what is the sequence of, protocol for echo that you follow? Like, for example, when a patient comes with no cardiac problem earlier, you're going in for chemotherapy. What is the sequence of echocardiography protocols? Is there anything that you specifically follow, or is this something which I'm interested in?
Yes, so I'm sure the practice may differ from institution to institution, but what we follow in terms of anthracycline-based therapy is that we have a baseline done,
Yes.
and we choose to, if the patient's traditional cardiovascular risk factors are high, we would choose to have a surveillance echo every 3 months till the patient is done with therapy. If the patient undergoes sequential therapy with trastuzumab, we would like to monitor the patient every 3 months with an echo and at the end of therapy. So that's basically a general guideline we follow for such patients. Yeah.
No, I've been doing it at baseline 3 months and 3 months. This is my protocol. But somebody asked what is a protocol? Is that the same thing that you follow in the US?
So that's basically what the FDA has recommended for any HER2 targeted therapy when you're treating someone with curative intent. I can tell you, for patients who are receiving HER2 targeted therapy in the metastatic setting, people don't tend to do it. It's a bit of there's no consensus. Although the FDA label says do it every 3 months in general for HER2 targeted therapy. In the metastatic setting, some people don't do any echoes. They do it if they become symptomatic. Some do every 6 months. It's all over the board. So I'm actually, and even if you look at what the guidelines say, like ASCO guideline, it says, do as clinically indicated, which means we really don't know what to do.
Yeah.
And the problem is, those FDA guidelines on HER2 target therapies, they were written like over a decade ago, and they've never been updated. So my argument is that probably we need to do a bit more work. I personally feel we're doing too many echoes in the majority of patients with getting adjuvant HER2 therapy. We need to risk stratify those patients and focus on doing echoes in those who are at risk, because the majority of women will be just fine. The danger is if you do too many echoes and you see an oncologist sees an EF of 49%, they're going to want to stop the therapy. But you and I know that if another person reads that echo, it could be 55% or 48%, because it's within the margin of error of reading an echo. But most oncologists don't know that. And so there is a danger in doing too many echoes in what I'll call otherwise healthy people. And so that's my area of interest in research. And I think in the metastatic setting, I've also heard that people say that, we don't need to do echoes unless patients become symptomatic. And I would argue that we need to look at that population a little bit as well, because people can live with HER2 targeted therapies with metastatic disease for years. So do we wait until they develop heart failure and then start doing echoes? Or, should we again be risk stratifying them and saying, if you're at high risk and you're on long-term HER2 targeted therapy for metastatic disease, we should periodically do some testing, because we want you to stay on that HER2 targeted therapy to control your disease. We don't want you to develop heart failure. So I'd say that what we have to do is take the FDA recommendations were very broad. We need to take those recommendations and we need to sort of refine them to the patient population, take some away from the, too many on this side with the early stage disease, and maybe think about a bit more about what we do in the metastatic setting. And I'm not saying that, everyone in the metastatic setting needs to have an echo, but we do get those very high risk patients that we're concerned about. that maybe we should be periodically following. So we need a bit more of a systematic approach to that. So that's a long-winded way of saying, yeah, sure. And oh, by the way, in terms of following the FDA recommendations, there was a paper published a few years ago by Chavez McGregor from MD Anderson showing you compliance rate with doing echoes in the HER2 positive curative setting is like 38%. Really, it's pitiful. So, I mean, everyone says that, but they don't necessarily abide by that.
Yeah, one
In the US.
question to Hisham. So
Yes.
these patients are at high risk of developing cardiovascular disease.
Mhm.
So do you lower your targets for your targets for blood pressure or lipids? Are they lower, or what do you advise?
No, sir. I think we would go along with the standard recommendations for lipid targets and hypertension. See, most often, some of these patients, sometimes clinically, they might not tolerate very aggressive and high doses and multiple medications for blood pressure to meet those aggressive targets like a sprint trial population. So I don't think we can replicate the kind of aggressiveness in the sprint trial to these patients.
Like that, really,
Yeah,
see,
yeah.
patient is having high blood pressure and if he's in pain, the pain cannot be satisfactorily controlled. Then the target is systolic 160 by 90. And in others, it should be 140 by 90. But the patient on cancer therapy, the blood pressure really fluctuates. So it is recommended that patient be monitoring the blood pressure themselves. And the ESC actually recommends even a particular machine itself. Like you have to armor on the BP recorder. Patient be trained to take BP, and there should be drug-free days. Days when the BP is really low, patient can actually skip the drug. That's being recommended. That's what the ESC recommendation says.
There's one question, that is, how often do you see Takotsubo cardiomyopathy during chemotherapy?
It is supposed to be even 30%.
Yeah.
30% patients actually.
I think Dr. Susan has to leave.
Yeah.
I think Dr.
Thank
Susan,
you.
thank you so much
Sorry.
for participating. Yeah.
Sorry, I have to go to clinic, guys.
Yes. Thank you so much.
Thank you.
Thank you so much.
Yes.
Thank you.
Okay, bye-bye.
Bye.
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 Many patients actually, chemo-related LV dysfunction, even in the earlier days itself, see the conventional therapeutic drugs like adriamycin and cyclophosphamide, they are the only one really implicated as causing cardiomyocyte injury. So, but many patients who have many of the conventional agents do develop LV dysfunction. And some of them are actually stress-induced cardiomyopathy. But the problem with this is the mortality of those patients who develop stress-induced cardiomyopathy with cancer therapy is equally high at the end of 1 year compared to somebody who has LV dysfunction secondary to myocyte injury itself. So it's not that benign as we really assume.
And Dr. Purvesh,
Dr. Purvesh, you are keeping silent. My
Yeah.
question to you was, how do you suppose you have somebody who developed a cardiovascular problem during your chemo? Would you reduce the dose drastically, or just wait and watch? Unmute, please.
Apologies. I think we've had several discussions on this with Hisham and Rakesh earlier. As far as possible, if the cardiologist says that it is reversible and you can continue with the full dose, for a curative patient, that is what we like.
Yes.
In case it's a palliative setting, then we don't want to provide unnecessary toxicity. We want to maintain quality of life, and there I would be happy to reduce the dose. But for adjuvant setting, breast cancer or Hodgkin's disease or non-Hodgkin's lymphoma, I would be very keen to continue the full dose, provided you agree to that.
Hisham, do you start all patients' potential of cardiotoxicity on ACE inhibitor, or what is the policy, or you are waiting for the trials to do the final
As a
answer?
preventive measure,
I think
Hisham, go ahead.
It's okay. Okay, yeah. So it's an interesting question. So right now, based on the data, we really don't have solid evidence. I think we have some trials like PRADA and Manticore, which looked at, try to address certain questions. But interestingly, 2 years ago, we gave one of our residents a dissertation to look at to conduct a small randomized study within our hospital. We divided into two groups. We randomized it into one group who received carvedilol and enalapril, and the other patients did not receive this. So it was just a pilot study. We couldn't conclude anything much. We did see some less troponin rises in the medicated group, but I think it was a short group. But I think, sir, to answer your question, I think probably to make it a part of our practice, I think I would personally wait for data. But on the other hand, I think if I have a patient with a high traditional cardiovascular risk burden and the patient needs anthracycline and sequential trastuzumab, probably I would lower my thresholds in such a high risk subset. There's no longitudinal real data to say this might benefit, but I might treat it on a case-by-case basis based on the risk.
There's a big problem here. The thing is, all these drugs, ACE inhibitors, ARBs, they all work on neurohormonal manipulation, which when the cardiac output falls. So in early stages, it is difficult to assume that they're going to work to prevent it, because these drugs have no known mechanism to prevent a cardiac injury. If you want to really prevent the cardiac toxicity from occurring, you should prevent a cardiomyocyte injury. So none of these drugs are known to act in that way. So even if there's an anecdotal report saying the beta blockers might help, it might help some arrhythmias at the onset. But per se, that's why even the GLS is superior to detect early onset of LV dysfunction. It really has not made any meaningful difference to the outcomes in terms of treatment. Like, what are you going to treat? Because the heart failure has not yet occurred. And both beta blockers, ACE inhibitors, all of them work by neurohormonal manipulation, which is that the target is not there. So if you give a drug when there's no target, you are going to invite more and more complications and side effects. So I don't know whether that's going to work.
Yeah. I would wait for more. I would wait for more larger data sets before it becomes regular practice.
Is there a point in doing? Is there a point in doing? This is again my own doubt that I'm asking. Is there a point in doing BNP or troponin halfway through the treatment schedule of a patient who is undergoing chemo?
The troponins definitely indicates that most patients who are on adriamycin, you can find a troponin elevation. But
BNP
essentially.
Patient may be asymptomatic, but is there any role to pick up people who are subclinical?
Visible in certain situations, like BNP essentially means an increase in the central venous pressure. So if patient is on some drug like carfilzomib, which causes significant diastolic heart failure in up to 50% of those patients, are those patients who are on even the imatinib kind of drug, where the fluid load happens. In them, there's a point in doing BNP, but it has to be individualized. Majority of these patients do have weight gain, and then if you in this setting, BNP may really be useful. BNP does not translate into a cardiac side effect which has occurred out of the chemotherapy per se. And if you've been troponin to, many patients who receive doxorubicin have myocyte injury, that troponin will be elevated, and that is in children. This can be done to predict, but the problem is the cardiac pump failure typically occurs in about 3 years to 5 years after, or even 10 years down the lane. So the troponin, if you elevation do indicate some myocyte injury, but majority of them may not translate into clinical benefit by terms of monitoring that.
A patient who was completely cured of, for example, a Hodgkin's disease. So what frequency of follow-up do you recommend?
Currently, it is 3 years.
Absolutely, he become normal cured. So he is at his 40s, for example. So what frequency of follow-up do you advise? Not from oncology point of view, from cardiovascular point of view.
It is recommended 3 years, then 5 years, and then 10 years. One of the recommendations, but it's always institutional based. One problem with this, see, if these patients on treatment you monitor and then treat them with ACE inhibitors, beta blockers, many of them come back and ask, now the LV function is normal, should I continue the drugs? It's very important to continue, because if the patient develops recurrent LV dysfunction and heart failure, 60% of those patients will die in 1 year. So if patient has got something like adriamycin, cyclophosphamide, and then if develops LV dysfunction, the treatment is going to be lifetime. But the only thing is the trastuzumab as reversible, mean, it affects the cardiac myocytes by uncoupling of the energy mechanisms. So it is, almost always reversible in 6 months' time, except maybe in 1% of the patients.
So
I think
Purvesh was saying something.
Yeah, in pediatric
manage
oncology,
manage
we are concerned about the late effects of more than one problem. So, like you mentioned in Hodgkin's lymphoma, in addition to cardiovascular effects, there are effects on the neurocognitive function, there are effects on growth hormone, there are effects on thyroid, and therefore most pediatric oncology departments will have a special clinic for late sequelae and late effects. And that is also known as after completion of therapy clinic. And I think there is a lot of work that has been done at several centers, including from Tata Hospital, as well as All India Institute of Medical Sciences, which has been also published.
Many children who get the adrenomycin in childhood and survive into adulthood, they may still have heart failure, but because they have a small sized heart for their body surface area. So you have to index it to find that really the cardiac output looks, ejection fraction looks normal, but
Yes.
that won't affect enough compared to the body surface area. So that's
Very
an
important.
important and difficult problem to manage. Their functional capacity will be significantly lowered.
Chopra, you were saying something?
No, I was saying was to continue the therapy. I think we have to follow much like what we do in myocarditis versus cardiomyopathy. If it is a reversible cause, then of course you give it for a shorter period of time. But if it is one of the chemotherapeutic agents which has got permanent damage, then as Hisham has mentioned that even if the LV functions are recovered, you have to continue it lifelong.
Yeah, that is that a Trudge of trial has shown that 45% of the people who stopped they did a randomized trial, very bold trial actually. 45% of them had a recurrence in 3 months' time.
Yes.
So I think it is recommended to continue lifelong, or if you want to reduce it, you can first reduce the diuretics, then stop one by one and see whether there is any recurrence of, if there is any minor recurrence of or deterioration of LV function, immediately you have to put on the full treatment which he was on. So that is the recommendation which is there. So we have to be very careful in patients who already had LV dysfunction and has recovered, because there is a high chance that they will go back into LV dysfunction again.
These patients,
Sometimes
I don't put them on
LV
diuretics.
dysfunction, next time they may not recover.
Your voice
Okay.
is breaking, Dr. Chopra. We can't hear you.
No, I'm saying that many times, if you stop the medicine and they go back to LV dysfunction, next time they may not recover to the original level. That
Yes,
also
yes,
happens.
exactly.
That's what Rakesh was saying, exactly the same thing.
This, majority of my patients, I don't put them on diuretic at all. I tell them to give diuretic only for symptom relief. So that will allow us to give the maximum tolerated
blockers and
dose of vasodilators. So,
It is
patient hospitalized, I give only one single shot at upfront. No diuretic after that.
It is early yet, but has anybody used SGLT2 inhibitors in this?
Yes, I've been frequently using. Almost all patients with LV dysfunction, we put on dapagliflozin. All of them.
And
Even
there's no hemodynamic
without
disturbance.
diabetes also.
Yeah, without diabetes. It is only sacubitril/valsartan plus dapagliflozin, in my opinion, gives significant symptom relief.
And without any hemodynamic compromise.
No, yeah, usually no.
Yeah, it has some amount of diuresis, so
Yes,
that will.
yes, yes, and that doesn't cause hypokalemia, hyponatremia, nothing happens. And patients are really happy. They come and tell, Dr. Krab, you added that drug. It is, I'm feeling so good. I can lie down flat at night.
No, I think this is a very important thing, because SGLT2 may be another weapon for people with LV dysfunction undergoing chemotherapy.
Yes.
The only thing is they are immunocompromised, and the chance of infections are urinary infections must be much more. So we have to be very, very careful maintaining the genital hygiene and all.
Yes.
Some of my patients actually lost 16 kilograms after putting on dapagliflozin in 10 days. Failure.
Oh, weight loss with SGLT2 inhibitors is 4 to 5 kgs. This is probably diuresis and fluid loss.
Exactly, because it's fluid loaded. She was not responding. If you give diuretic Lasix to her, she was always developing hyponatremia, and then comes with drowsiness, that kind of thing. But she's been doing quite well after that.
Probably we need to close now. We are well past.
I think we had an excellent discussion, very, very interesting question and answer session also. I'd like to thank Professor Dent, Dr. Hisham, and Dr. Purvish for the excellent contributions they made. Thank you very much. And Rakesh for a very interactive session. And thanks to Dr. Hari and Dr. Chopra. Please conclude.
Yeah, we had a very good discussion, and I think it is a very. I think this is an area where we have to develop, both of us, oncologists and cardiologists should sit together. We should form something like a hard team to go forward to help more patients. I think the interaction will. I think we have a regional cancer center nearby, and the interaction with the oncologist are very. They send consultations, we send back the consultations, and the interaction is not there. Probably once we interact, it will lead to fruitful outcomes of these patients. Second is this is the third program of this monthly seminar. The next month, December, we will have the program on arrhythmia devices in heart failure. So we will inform you about the details of the program. Dr. Belbir Singh from Delhi will be coordinating the program. Over to you, Dr. Chopra.
Well, I think thanks everybody. Wonderful session, very interactive, and we look forward to subsequent sessions. And I'd like to thank all the panelists.
Lupin for this platform and the arrangements.
Thank you.
Good night.
Thank you.
Everybody.
Stay safe.
Good night.
Thank you.
Good night.
Bye.
Thank you, sir. So I'm ending the meeting now. Thank you.
Thank you, Ankur.